Yeah, my name is Rachel, and welcome to our video on using interventions to help people recover from persistent physical symptoms, such as after COVID-19 and people diagnosed with ME, CFS. As I said, my name is Rachel. I'm the chair of COFFI and the consumer arm of COFFI. And COFFI is a group of international scientists that have been going for 10 years, collaborating specifically on fatigue post-infection and other symptoms, but specifically fatigue. And really, the role of myself and some of the other consumers is to ask questions of the scientists and try and communicate those findings in a way that makes sense, that is a language that people can understand, particularly the language that patients understand. And certainly myself, I've seen so much research that's gone viral, particularly in the patient groups. I recovered myself from the post-COVID condition, but you often see things from a molecular perspective, and often a lot of kind of just things that don't really fill you with hope. Whereas today, what we really want to talk about is interventions using a mind-body approach, which is the approach that I took myself to recover, but with enough detail that people know at least how to start on that journey of recovery. So we've got 4 scientists today that are involved in randomized controlled trials, all using a mind-body approach. And I'm going to go round and introduce them, and then you'll hear more about how they really helped and are helping their patients recover. So we've got Tom, who has been involved in the Norwegian outplacement programme in Norway, using a mind-body approach to help patients with long COVID recover. We've got Cathrine, who's been using a communication tool to help GPs when they, people in primary care, to help when they see patients, to help them find ways of recovery. We've got Maria, who's also been involved in a trial using mind, body, and medical approaches and comparing. And then we've got Valina, who is still involved in a trial that's not completed yet, looking at the Gupta Programme as one of the arms of the trial. But we're not really interested today in terms of the results. What we're really interested in today is looking at the theoretical basis for the treatments. And specifically, how do you link that theory to giving patients credible explanations that they can understand and believe and have faith in? And probably even more importantly, how do you then help patients particularly kind of turn the corner and start to find ways to recover and go back to their normal life? And with that in mind, I'm going to ask Tom just to give us a bit more information about your trial and how it's helped your patients.
Thank you so much, Rachel. Talk shortly about the Norwegian Brief Outpatient Rehabilitation Programme for post-COVID-19 condition, a pragmatic randomized control trial which was effective and safe. And we have kind of 4 important things that we believe the patients need to, not to agree on, but at least be curious on. We say that step 1 is always the first meeting. Listening to the patients, trying to understand what they've gone through, how they feel, what they've done for different diagnostics tests and images, etc. And then when we have that and we believe that we are still in the kind of area of persistent physical symptoms, we do try to bring in a new understanding on how symptoms can sustain. And our explanation is connected to a theory called the cognitive activation theory of stress, which actually says something about how an abnormal perpetuation of the acute sickness response can give a wide range of bodily and unpredictable symptoms, and that these symptoms are viewed as normal after an infection and not necessarily related to organ damage, which I believe is an important switch in the explanation, giving a reassurance that it is possible to go further to explore cognitive and behavioral approaches, but giving that kind of, you can call it an educational part. We do hope that this gives a further curiosity of, okay, what can this mean to me? What can this mean to me for a change? Is it something that I've done before that maybe it's not been the best way? And then if we get this understanding and we get the conversation going, the dialogue, the curiosity, we maybe get some hope in there. We are actually just trying to give them a reassurance, both a cognitive reassurance and a more physical reassurance that the body needs activity. The body needs to pursue physical and mental tasks for recovering, for getting better. And then that is what we work on in our sessions together with the patients. And we are not deciding what they are supposed to do or what they are exploring. We try to just make it individualized in the patient meeting, and we try to find ways out with physical and mental tasks as a part of it that is suitable, feasible, and enjoyable for each and every one patient. And then, of course, we do hope that their experiences over time will kind of give what we call a positive stimulus expectancy, or making them cope and then somehow explore better physical function and less symptoms.
Thank you very much, Tom. And I remember when I first heard about the trial, when it was still in the early stages, but you've been running this program. And I was amazed that your explanation was a very similar explanation that I used, but I didn't know it was being used in actual, an actual hospital programs. And I think you talked about the fact that you'd taken the work that you did from working with chronic pain, which was also something that a lot of people with long COVID who were recovering had started to do. So really impressed, Tom. Thank you very much. Cathrine.
Thank you, Rachel. Yes, my trial is, I'm a GP myself and a researcher, and this trial where we tested out this communication tool for GPs, which I made because I was frustrated, didn't know how to handle these patients in primary care. So, and this is made by, this is also a mind-body approach and a structured communication tool. And this randomized control trial is conducted in primary care with normal GPs and real participants. So first of all, the GP and the patients go through the examination. So the GP and the patients agree that the patients don't have any structural damage. And then the patients, the GP validate the patient's feelings. The patients need to feel understood. And then they're using an explanatory model to explain the symptoms. And this model is show how prolonged stress, whether it's a physical stressors or life stressors like grief, trauma, or relational difficulties, for instance, can keep the body stress responses going on. And when it's not downregulated, it can cause imbalance over time. And then the body is affected with various symptoms, for instance, fatigue and pain. So this explanatory models is giving out to the patients as a paper copy. And so they go on by try to sort out what's the sustained prolonged stress in the patient's life, or what they do to help them to cope with or avoid long-term stress. And the main goal is to achieve balance and downregulate body stress responses. So the GP then, after explaining symptoms, goes on with making a job list to see what the patients can do at work if despite their symptoms, if that's the problem, or a list of opportunity to sort out what they have stopped doing, which was good for them to cope with long-term stress, or a problem list. If the patients feel overwhelmed by problems, the doctor can create a bullet pointed list and then try to help to sort the problems and pick one problem which the patients mean is solvable. And then the doctor and the patients make and agree on a specific activity plan, which they may cooperate and record in the patient's medical record. And finally, the patients having a paper copy of this activity plan, homework for the next session. So this is how the GPs, just a brief introduction, how the GPs use this structured communication tool, which help the patients.
Cathrine, thank you so much. I really wish that if I'd have gone to my own doctor in the early days of post-COVID, I would have had something like that, Ron being told they had no idea and to go on the patient groups. And that stress response was a real light bulb moment for me and a real kind of turning point. The idea of work, it's quite a balance, isn't it? Because I remember my world shrinking and a tremendous amount of fear in terms of going back to work. And yet I found when I did it in a planned, very gradual way, it actually was also the turning point in terms of kind of going back to normal and having something different to think about. So I definitely think there's lots of really good things in there. Thank you very much. And Maria.
Yes, thank you, Rachel. Well, our research were on adults with long COVID. Typically, they've been bothered for symptoms for over 2 years, so they have tried a lot of different treatments. The patient that came to us receiving the mind-body reprogramming therapy. So the mind-body reprogramming therapy is based on new neuroscience, the predictive brain theory, and also what we know about symptom perception. It's happened a lot in neuroscience the last years, so we incorporated the science within the treatment. So what we did with the patients, they first had a session with a physician where they went through all the assessment they've been through, their blood work, other examinations, and really trying to find out if there's something really stressful or they're worrying about a special symptom or a special disease. And then we go into what are symptoms, because as all of us know, symptoms can of course come from tissue damage, but the most symptoms and chronic symptoms especially usually don't come from tissue damage. It comes from symptoms being a brain function, and we talk a lot about neuroscience, about how what symptoms are, how symptom perception work, and what we can do. When given the explanation, it was surprising to see how they understood and how it made sense, because making themselves feel and understand with their self-experience is really important. What we tell everybody, it's not a thinking therapy, it's a doing therapy. So they have to, as if I had prescribed any medication, antibiotics for instance, the antibiotics would not have worked if they didn't take the pill. So they had to do the exercises that we gave them. So after the first session with a physician, they had 3 sessions with either a psychologist or a psychiatrist, where they learned, they got more self-experience with symptoms. They also assessed deeply how they respond to symptoms in their everyday life and tried to find out how they could respond differently. And they assessed what is important for you. That's really important when you are working to get better. What could you do more of? They also worked a lot with how to understand symptoms, why does the brain work as it works, and finally they also went through how they can do a mind-body reprogramming therapy on themselves. So they had these 4 sessions were within 2 weeks, and they also had internet resources to help them along the way.
Thank you very much, Maria. That's amazing. And I love the way you talk about symptom perception. I mean, one of my most bothersome symptoms was a tight throat, so tight that I could hardly talk. And when I Googled, it said it was called the COVID throat. And so the meaning I placed on that in terms of being broken was huge. And actually, I find that it's quite a common stress response. And when you see it purely as that, I still get it now. It has a completely different meaning and a completely different way of, I don't then spiral with what it means and I don't feel broken. I just see it as a message that I maybe need to deal with some things going on in my life. So thank you, Maria. And lastly, Valina.
Yes, thank you, Rachel. So I'm also a general practitioner, and I work at the Helsinki University Outpatient Clinic for rehabilitation of persistent symptoms. So we see patients who have been referred to us from primary healthcare, and we have a first appointment with the patient, meeting a physician, where we really try to validate the patient's experience, their symptoms, and give them a slightly different explanation than what they possibly previously have received. So we also talk about the brain and how our brain and our defense systems in the brain participate in the production of these symptoms. We try to relate the person's individual symptoms to their individual situation, and also take into account the personal factors that might be influencing that particular person. And then as one option, we offer the Gupta trial, which is a part of our randomized control trial with 2 other interventions as well. So the Gupta trial is also called amygdala and insula retraining therapy, and it's done online. We have translated the program into Finnish, and we have a manual that we also give to our patients. And the program itself lasts for about 2 months. There are daily exercises that you are supposed to do. As my colleagues here already stressed, it's also about doing, not just thinking. It's doing differently and acting differently as a response to your symptoms, and teaching your brain to sort of react in a different way, which is more beneficial from your health and well-being perspective.
Thank you so much, Valina. There's so many really good things there. I mean, I just personally remember listening to the Gupta Programme, and just the explanation was absolutely key in terms of me turning a corner and having an upward trajectory. And I remember him reading out a list of statements, and he said, "I bet you think you'll never recover, and this is it for life." And I honestly thought that he'd been listening into my brain somehow, because that was exactly what I was thinking. But again, it just made sense. Valina, I love the way that you talk about, it's not just something that you can listen to once and then that's it, like a pill. It's something that you actually have to consistently do on a regular basis. And it's about taking action. And it's about how you think differently and how you want to be, rather than just a kind of tick box exercise. So I love the fact that you mentioned that.
Yeah, and actually, if I can just add to that, I think it's really important that you understand why you are acting differently. You have to believe the explanation. If you don't believe the explanation, really, it's very difficult to be courageous enough. As Tom said, you need courage. You can also be courageous and say, for 2 months, I'll believe this 100%, and then I'll see what happens. That might also be a good way of dealing with it. Give yourself a chance.
Yeah, absolutely. And I definitely see those people that are really bought in and really committed, and the difference that they can have in terms of results and moving forward and increasing activity, and those that haven't really bought into it and think that they are sort of physically damaged. Thank you so much, everybody. And I'm really interested now, just in the discussion, when you've listened to each other, what are your thoughts in terms of what have you got in common? What are the sort of trends that maybe are really key when it comes to communicating this work to patients that might be at the beginning of their journey, that might help them? And Cathrine.
Really nice listening to your colleagues. Thank you. Well, I think, first of all, validation, explanation, and action. I think that's what they all got in common and what is important to recover. And here we have both Valina and I are general practitioners, and then we have outpatients clinics. So at the patients can have got help on different levels in the healthcare system. And that's what I think is very important.
Yeah, I agree. And I think it's very important that the patient gets a sense of agency. I can do something about this myself. I don't need to rely on others to help me. I can be active. I can choose. I can sort of go forward to being myself.
Yeah, that being able to actually have influence rather than just, I thought initially that a crash meant that I just had to hide in bed and just cross my fingers and hope for the best, and there was nothing I could do. And that difference in terms of that sense of agency, I totally agree. And I do think, if your first visit is to primary care and you get something like Catherine's talking about, the difference it makes really early on in your journey, with someone understanding your story and validating and showing you a path, I think is really incredible. Maria, any thoughts?
Yeah, I've been thinking a lot about how important is it for the patients to really understand what a symptom is, because that a lot of the research, the treatment we are testing out are based on neuroscience, what really a symptom is. But I don't think it's that important that they understand actually what it is, but that they get enough, as been mentioned, courage and hope to try to do something different. What I've been doing up to now hasn't worked, so maybe I should try to do something different. And trying to be safe in, be reassured that, okay, it's nothing wrong in my body like I thought it was something wrong in my body, because the symptoms are so in the body. So everybody that comes to me says, oh, it's something wrong with my body. And trying to explain how the brain is perceiving everything and makes us consciously aware of everything, also symptoms, is important. And we are working on several levels, and in this field, we know also that something as easy as an information leaflet when you first get sick, that, okay, this is nothing to worry about. You could have symptoms that persist for some time, but that's totally fine. Just don't go for gold, and you will be fine. Your body will come back to normal. That also show effect, so that we could be at different levels within the healthcare system is really good.
Yeah, and you're right. There's a lot of fear in terms of what to do and the feeling that you are broken because you feel really broken. But just that reassurance is really helpful, Tom.
Yeah, just continuing on what they're saying, because I do believe that with our way of working, we come forward with a new understanding. We're making sense of symptoms in a different way, not as a damaged body, but as a brain function. And by that, we also give the patients an opportunity to meet their symptoms in a new way when they appear, to understand them in a new way and to act in a new way. And I believe that is what we're bringing to the table, with some confidence, and for sure with an body optimism that the body has the potential for adapting, has the potential for getting better, has the potential for recovering with these kind of treatments.
That's such a good point. I was encouraged to symptom diarize, and actually I think that was probably the worst thing, because then the focus and the fear and the looking for patterns, and when I stopped doing that was also key. Cathrine.
Yes, that's very important what you say, Tom, about having been optimistic, and also about what I thought about what I see in general practice. The patients come back and say, all your test is normal. We didn't find anything on the blood test, MRI, and so on. So just saying that can make the patient hear, well, it's nothing wrong. It must be something wrong with me then. The doctor isn't interested. I don't get an answer. And that's also that a lot of these patients feel stigmatized in the healthcare system. So just explaining the symptoms, they are real. It's not your fault. You don't choose to have your headache. It's very important.
And just to add, also, I think it's really important to educate the relatives, the family as well, so that when the person starts acting in a different way towards the symptoms and understanding them in a new way, it's very important that the people near them also have that same understanding in order to be able to support the person in the right way, not to give mixed messages and activate the internal alarm system unnecessarily.
The ability to co-regulate, I agree. Cathrine?
I just have a short comment to that. That's why when we now 1/3 of all GPs in Norway have been trained in using this communication tool, and they're instructed to give the patients a paper copy of the explanatory model, just because we wanted them to explain for their relatives and friends and families that symptoms are real.
Yes.
That's great, Tom.
Yeah, and when or if patients do find our explanation, which is a bit different but still quite similar, I would say that then we are ready to act together and go further with the shared decision making the patient the project manager, and we're being there with them, exploring, trying to individualize what they want in their lives, what they miss, what they we can be there together with them, but it is the patient's project, but we try to individualize it. We try to make it suitable, feasible, and enjoyable for every patient. But they are in the driver's seat, as we say in Norway.
Yeah, absolutely. I remember hearing about your child, Tom, and that focus on joy, and finding something that you are really motivated to go back to, because your world can really shrink with these conditions, and just encouraging people to open up with something that they want to do first, I think, is really key.
Yeah, we try to climb up this downward spiral and try to go the other way around. And if you want to sing, you go out singing. If you want to see your son playing a football match, that's our first thing to do. Yeah, that's how we work.
I love it. Maria, you're nodding.
No, I completely agree. It's so important that it's the patient that's the main character here, and we have to individualize, and they have to understand that it's their project and we're just helping them along.
Yeah. And I think something all of you have talked about is kind of activity and getting back into the world. And certainly I remember being really frightened of movement in case I did something wrong, and different activities. I thought, what if it makes me crash? What if it makes it worse? But actually kind of getting over that fear and starting to do normal activities and go back to life was really key for me. Tom?
Yeah, our explanation is therefore giving you a reassurance that symptom flares, symptom variation is something expected, nothing that we fear, to be there together with the patients. And yeah, I would just wanted to point that out, that is important. And then I believe that they are understanding more and more that recovery really needs an active pursuit of physical and mental tasks, and not just only rest and avoidance and trying to avoid symptom flares.
Yeah, I think once you view the symptom flares as differently and part of the process, it makes a huge difference, rather than doing everything you can just to avoid. Thank you very much. We've got time for one or two more comments before we need to wrap up. Has anyone got
I just wanted to
Valina?
add to what Tom just said. You basically need the symptoms in order to teach your brain to act differently. You cannot teach the brain to act differently if you don't have the symptoms. So it's really, you sort of need them.
Yeah.
And when you approach it in that way, as you, Rachel, said, then you sort of take that as an opportunity. And that is your opportunity, actually.
And that's a real paradigm shift, isn't it? That's a real kind of leap of faith to understand that and almost welcome them and look at them as an opportunity to be part of the path out to get better. I agree. Anyone got anything final to add before we wrap up?
It's hope for
Yeah.
resistant physical symptoms.
Yeah, and definitely on behalf of the consumers at COFFI, I think you've given me hope today, actually. I look back at my own journey and think if I had met any of you as professionals, then that would have made a massive difference, you know, particularly in terms of the explanations, in terms of the tools to be able to have confidence, and just taking away that fear of activity and giving you courage in order to be able to choose a path out, I think is really key. And what I'm hoping from this video is that we give people that are maybe at the beginning of their journey in terms of recovery some hope, but also some pragmatic tools to start to find their own ways out. So thank you very much. And it's been an honor. It really has. Thank you.
Thank you.
Thank you.
Thank you, Rachel. Yeah, bye.